Hello and welcome to day 2 of the 24th Biennial General Conference of the Association of Asian Social Science Research Councils. My name is Michelle Bruce and I'm the Secretary General of ASREC. The topic of this year's ASREC conference is Navigating the Future with and After COVID-19, the Role of Social Sciences in Asia. And it's being hosted and convened by the Academy of the Social Sciences in Australia. It is customary in Australia to offer an acknowledgement of country at the beginning of a meeting, speech or event. So I'd like to begin by acknowledging the traditional owners of the lands on which we are joining this event from today, and we will do this with a brief video presentation.
Wherever you are across Australia,
we acknowledge the traditional owners and custodians of this land.
The Darug peoples.
The Gadigal people of the Eora Nation.
The Gundungurra people of the Southern Highlands.
The Ngunnawal people of the Canberra region on whose country we are standing.
And all other peoples of this vast continent.
Their ongoing connection through custodianship of its land and waters.
Physical and spiritual.
Through culture, language and ceremony.
Where sovereignty was never ceded. We pay our respects to elders past, present and still to come.
Thank you. The ASREC Secretariat is located on Ngunnawal land in Canberra, and that's where I'm joining you from today. And I pay my respects to elders past, present and emerging. Now, for those of you who weren't able to join us yesterday, I'm going to run through a few housekeeping matters before we begin the presentations in session 3. The conference is proceeding as a series of 5 webinars with a different joining link for each session. Now, each session will consist of 15-minute presentations from each of the presenters, and following the presentations, we'll hold a Q&A session with all of the panelists. So if you'd like to ask the presenters a question, please type it in the Q&A box at the bottom of your screen. And we also encourage you to use the chat section to enter any comments you may have on the presentations. Please note that this event is being recorded and the recording will be available on the ASREC website after the conference. And just to clarify, we won't be recording the participants, we will only be recording the presentations. It is now my pleasure to introduce the chair and moderator of our 3rd session, Professor Linda Connor. Professor Connor is an Emeritus Professor of Anthropology at the University of Sydney and a Fellow of the Academy of the Social Sciences in Australia. Over to you, Professor Connor.
Thanks very much, Michelle, and welcome to everybody to this really interesting panel this afternoon, looking at public health strategies during the pandemic. And I'm interested to see that we've got a range of different disciplines and of course different countries. And we're going to look at perspectives from disciplines of finance, psychology, communications, regions of India and the Philippines. So looking forward to it very much. And just to say, the presentations will be 15 minutes, and I will give a little verbal reminder to the presenters if they need it, if they're running a bit over time. So I'd like to introduce the first speaker, and that's Dr. Elena Pernia. Elena is currently Vice President for Public Affairs at the University of the Philippines System and Professor of Communication at the University of Philippines College of Mass Communication. She has over 30 years of experience in communication and media education, research, planning and evaluation. Her highly distinguished academic career focuses on building the capacity of students, local governments, health professionals and civil society organisations to design, implement and evaluate their own communications programs. And she's going to talk about a very important one of those right now. So thanks very much. Over to you, Dr. Pernia.
Thank you very much. It's afternoon here in the Philippines, so I'm greeting everyone. A very pleasant afternoon. Okay. there's a little message here that I cannot get rid of. I'll just move it there. Okay. So this afternoon, Diane, can you please help me with the slides? Thank you. All right. There we go. All right. This afternoon, I'm going to present to you the results of our research study, which we titled "Communicating COVID-19 in Post-Quarantine Philippines." It's a study that took 8 months to do, from October of 2020 until May of this year. It was funded by our Department of Science and Technology, in particular the Philippine Center for Health Research and Development. The research team who worked with me represent various disciplines from the social sciences. We had psychologists, statisticians, and media and communication scholars as well. We wish also to acknowledge the great help and assistance we got from the public health doctors of our University of the Philippines, Philippine General Hospital, the University of the Philippines, Manila, the Philippine Department of Health, and the WHO Philippines, who provided us with medical backstopping in the production of the public service ads. And most importantly, I also want to acknowledge our private sector partner, IPG Media Brands, for their assistance in doing the social and emotional listening and sentiment analysis. Next slide, please. The study is anchored on literacy, in particular health literacy. We all know that it seems trite now to say that with literacy there is power. You know, for the longest time, literacy remained a very restricted technology, closely associated with the exercise of power. Literacy leads knowledge, and knowledge power. But these days, we acknowledge literacy as a driver of development, in that it enables greater participation in the labor market, improved child and family health and nutrition, reduces poverty, and expands life's opportunities. Literacy is more complex than being a dichotomy. One is not either literate or illiterate. Rather, one can, next slide please, one can talk about literacy as competency, and therefore existing on levels or dimensions. Literacy, health literacy in particular, can be looked at from the dimensions of foundational knowledge, technical skills, and critical assessment, which is why we say that there is no person who is really health illiterate. You know, one can be more health literate than others, depending on the amount of knowledge, skills, and critical assessment that one does. In the area of health, literacy requires a complex group of reading, listening, analytical, and decision-making skills, as well as applying these skills to health situations. It is this kind of competency-based approach that, for us, provided the appropriate framework in promoting and assessing a population's health literacy. Let me now walk you through how we applied this health literacy framework when we designed our research program, as well as the communication campaign. When the Corona SARS-CoV-2 made its appearance on Earth, the whole world was upended. But it also gave us an opportunity to look into how literacy assists development, in particular in the Philippines. Our 8-month research project looked into the information sources and how this affects public perception and understanding of this coronavirus, how people look at and perceive the preventive measures and accept the policies and programs that are in response to the crisis. The results of this research provides the recommendations to instill healthy behaviors and practices in post-quarantine Philippines to prevent a resurgence of the disease by developing a communication plan that supports and strengthens various initiatives towards the transition to the new normal. Let me give you a context of how the COVID situation was in the Philippines. When the COVID-19 outbreak was declared a pandemic early last year, it also spawned an infodemic, with large numbers of people relying on online and social media to access real-time updates of COVID-19. Even well-meaning people spread misinformation, sharing false claims, giving erroneous warnings and false cures as treatment for COVID-19. You know, honestly, the social media helped by disseminating information, but it also hurt, you know, in the sense that a lot of this information were bogus information. Next slide, please. So what we did, you know, we heeded the need to improve COVID-19 communication in the country. We were a group of UP social science researchers and media and communication specialists, and we put together a project to develop a research-based COVID-19 communication plan. The project team focused our energies on determining strategies and messages that would instill these good behaviors that are supportive, you know, of what the new normal requires us. But the very first step to develop an effective COVID-19 communication plan, we felt, was to begin with assessing what the public cognitions were about the disease and the key supporting issues. So we formulated a problem, and it's in front of you. What is the current status of COVID-19 literacy among the Filipino public? And to answer these questions, we looked into three major indicators. First are, what do people know? What do people talk about? And where would be the intersection of media literacy and health literacy when it comes to media and message contexts? We followed the health belief model. Next slide, please. Yeah, following the health belief model, our study considered that effectiveness of a COVID-19 public health campaign is anchored on building health literacy of audiences. And the key to building COVID-19 literacy is to understand their situations in terms of their media access, their media literacy, and the contexts in which they receive information. Next slide, please. At this point, I will be sharing with you some of the data that we have gathered. I'm not presenting everything. I have selected certain data which I think would be sufficient for our time limit of the afternoon. First, I will be presenting some of the results of the social listening, and then I will be presenting some data from the survey and the qualitative focus group discussions and key informant interviews. Okay. To begin with, I'll give a context about the COVID-19 discussions on social media. Okay. Social listening was done on about a year's worth of COVID-19 conversations that were posted in public social media. Next slide, please. Here, you will see the trend of COVID-19 conversations in public social media from February 2020 to January 2021. In total, we found 156,000 social media posts that were made during that time period. And this reveals that COVID-19 really figured as a topic of public discussion throughout the time. Conversations about COVID are clustered around 6 general topics. The brown one indicated in the, in the graph is about the IATF. This is the Interagency Task Force on Emerging Infectious Diseases. This is the task force that was that's on top of our monitoring of the disease, including the health protocols and the treatments, including vaccination. Next to that were topics that were about the new strains. We know that there are various strains of COVID-19 that have, that has complicated the disease. And then another set of topics discussed were the vaccines. And then another was testing. The fifth one was about the Department of Health. The Department of Health is the one that is in charge of our COVID-19 response in this country. And then lastly, the health protocols. These health protocols are the same in most countries, which are to mask, to wash the hands often, and to keep good distancing between each other. You will notice here that the health protocols were really the ones that contained a lot of the social media posts, and that it was during the early days of the pandemic, until the end of our total lockdown, which was around March, which had the highest number of conversations. And then beginning in the mid-year of last year, there was a general decline in conversations and an almost flattening out by the end of the year, except that there were there were peaks in discussions about our three top topics, which were health protocols, testing, and vaccines. Next slide, please. Now I wish to show you that from these social media postings, we found these social media postings provided valuable information on the emotions that netizens expressed when they were posting these conversations. So you'll see that in the past 18 months of the pandemic and the consequent community quarantine levels, we, the Filipino public, have gone through various emotions of fear, anger, loss, compassion, and hope. What is clear here is that there is a mix of emotions, with anxiety being the topmost, anger being second, empathy third, and then some hope and a little boredom. But of all these emotions, anxiety is the most dominant emotion that was expressed throughout the period. Let me show you the same graph again, but with some timelines indicated. To give a context about these emotional spikes, I put in some of the events, that more or less triggered these spikes. Notice that the gray tones of both the graph and the boxes indicate anxiety. The blue indicate empathy. The red indicate anger. You'll see that there is no spiking on hope and hope and boredom. All right, but here the three top emotions that we really found were anxiety, and this anxiousness was reflected throughout the entire period. Empathy, and these were in Filipino, we have this term bayanihan, and bayanihan is like helping out the community, and it is a spontaneous and magnanimous action on the part of the individual and the community. And you will see that there were several spikes in this bayanihan, in this compassion, in this empathy. Next slide, please. What were the triggers for each of these emotions? For anxiety, which was the largest, there were profanities, swear words directed at the government for its inconsistencies, its perceived slowness in their responses. There were issues, there was anxiety over the availability of testing kits. And there were also angry tirades, expressed in the inabilities not to move out from one place to another. Fear, fear and anxiety being the most dominant also showed in cases where people reported that friends and relatives were testing positive for COVID or even dying. Fears were also expressed with advice to go panic buying for food and supplies such as alcohol and toilet paper. We realized that we did not have to do panic buying. But despite these negative feelings of anger and anxiety, our struggles with COVID-19 awakened our innate ability to sympathize, to empathize, and to become compassionate. Next to anxiety, empathy is the next dominant emotion. And these were indicated by calls from private individuals and groups, from companies and networks to support the frontliners via donations of cash and kind. And these were readily heeded by the online public. The data that I've shown you were for the first 12 months of the pandemic. I am sure that with our continued social listening, we will reveal other topics, shifts in topics and emotions. But for the time being, and for the purpose of the social listening in the development of our public service ads, this is where I stop with the social listening. Now let me go on to some other data that we gathered from the surveys and from the focus interviews. Next slide, please. To gauge current knowledge and comprehension about COVID issues, we did a quantitative telephone survey, 400 nationwide, along with online focus group discussions. The lockdown actually improved our data gathering skills now without having to move about and do face-to-face. The face-to-face that we did were mediated by the internet. Okay.
4 or 5 minutes left, Dr. Pernia.
Okay, so again, all right, thank you very much. We had a good number of our survey respondents who showed to be very knowledgeable about COVID-19 in general. Next slide, please. But there were some differences between their self-rating of their knowledge and their actual comprehension. What we did was to, we asked them several questions. We tested them to find out whether their self-rated knowledge was consistent with their with more correct knowledge. When it comes to transmission, there was almost a match. But when it came to issues about symptoms, preventive measures and treatments and vaccines, there were large differences indicating very poor, very, very poor knowledge about them. Next slide, please. This slide just shows you that vaccine acceptance is pretty low. All right. And now we go now into the research-based COVID-19 communication plan. Next slide, please. Okay. Putting together all the research data that we got, we found several things. Among them is that anxiety and fear were not good motivators for change action. We also found that when it comes to this, the intersection of media and health literacy, the media that were still the believable ones were our conventional mass media. Social media became problematic. So, putting all this together, we came out with this communication campaign where which we titled "Dahil mahal ko kayo, magpapabakuna ako," which translates into "Because I love you, I will get vaccinated." Filipinos connect emotionally to the messages embedded in stories. Hence, the culturally appropriate genre to build vaccine confidence and instill healthy behaviors is the narrative. We tapped into Filipino values of familial love and care. We made sure that our messages penetrated the fear of COVID by creating hope, which is focused on love. The campaign takes on a feel-good tone, emotional but science-based, using Filipino values as anchor. The selected targets for this group of ads that I'm going to show you are our senior citizens. Why? Because these are in the priority for our vaccination. The vaccination campaign that you will see uses narratives that are common experiences. Let me play you one. Next slide, please. Diane, can you play the first one? Okay. We will show you, it is in Filipino, but you will get the drift. The title slide says, Stories Behind COVID-19. Okay. Are there in sound, Diane? Please put on the sound. Diane, no, the 75th birthday, Diane.
Sorry.
Will it play?
Happy birthday, Mommy! Hi, Dad! Hi, Mom!
Birthday!
Love you, Mommy!
Miss na namin kayo!
I miss you, both of you. I miss you. Miss ko na kayong lahat.
Mommy, sana magkakasama na tayo muli.
Miss na namin, Mommy. Happy birthday, Mommy. Miss and love you, Mommy.
What did you wish for, Lola?
My wish? Magpapabakuna na ako.
Ako din.
Dahil mahal ko kayo, magpapabakuna ako.
So that was a story of a mother, grandmother celebrating her 75th in now these normal times of doing everything via Zoom. Okay, and the main message there is that I love you, I miss you, I'm going to have to be vaccinated so that we can finally get together. Do I have time to show one more video? May I? May I, Linda, one more?
One or two more minutes would be fine, Dr. Pernia.
Thank you. Diane, can you play Tropang Tigasin? The second video that kind of tone. Okay, go ahead, please.
Mahalaga ang lakad na ito. Tigasin ka ba? Siyempre! Mahal ba si Commander? Mahal na mahal. Pare, mahal mo ba ako? Oo naman, ano? Mahal mo ba ang tropa? Oo ba? Tara na, magpapakuna na tayo.
Dahil mahal ko kayo, magpapabakuna ako.
So you will notice that in this video, we played on well, satire, no, and whimsy, you know, and this one was directed at males, now looking at them as groups so that they can be convinced to go for vaccination. Okay, the IECs, yes. The videos that I showed you are just some of the collaterals that we developed. We also put together these materials for social media, and also posters for the use of our health workers as they do the vaccinations and health consultations, be they virtual and now increasingly face-to-face. All right. Next slide, please. And this is my last slide. What we found doing this plan is that there's this huge gap between how government and the public and the health institutions have been communicating. Unfortunately, the first COVID communication in the country were not quite coordinated, used a lot of fear appeals, which is why some individuals and groups were labeled, as those who are stubborn, hard-headed, and which did not do much to get them to follow health protocols. But so that's why we believe that these materials that we have shown you and which are now being rolled out by our health department and the private sector consider individual and community sensitivities. This kind of sensitivity is what is important for acceptance, and also important for maintaining credibility and comprehensiveness of the message. As the public health crisis transforms into a multifaceted social problem, we take to communication as a tool to inform the public about other things that are important for them to negotiate in this new reality. Thank you very much, and good afternoon.
Thanks very much, Dr. Pernia, for that really interesting presentation with some very interesting data there. I hope we'll have some time to follow up in the questions. I'm going to move on now to our second speaker, and that's Dr. Koustubh Kanti Ray. Dr. Ray is a professor of finance in the School of Management at the Kalinga Institute of Industrial Technology and a representative of the Indian Council of Social Science Research. Dr. Ray has a passion for teaching, and his research interests are mainly in the area of corporate finance and financial markets. And he's going to talk to us today about determinants of depressive symptoms among older people in times of COVID pandemic. Over to you, Dr. Ray.
Yeah, thank you. Thank you very much. I hope that I am audible. Am I audible? No? Am I audible?
Yes,
Dr.
you are.
Linda?
It's fine. Yep, you're fine. We can hear you.
Okay. So thank you very much for having me for presenting my paper. The paper title is that is Determinant of Depressive Symptoms among Older People in the time of COVID pandemic. And this is a project which is sponsored by ICSSR New Delhi in India. So, so far as my presentation agenda is concerned, I go by this agenda as background and the research question, prior literature, objective of the study, data and methodology, analysis and findings, and at the end I'll conclude my research. So far as the background of the study is concerned, that everybody knows that in last 18 months, that after that your Wuhan virus that is affected all generations in all countries. So because of this national lockdown, then community transmissions that restricted the virus rates, many governments they have taken corrective measures to stop the spread of virus in almost all the countries. But if you see the media reports, both nationally in India as well as elsewhere, what we find is this coronavirus has affected significantly to the older people generally. And during 2020, WHO, they also reported that the older people in the society face significant risk due to their physiological and psychological changes that comes with aging and the health conditions, deteriorating health conditions. And again, because of this coronavirus, that particularly the older generation, they face lots of stress, anxiety, and insecurity, and ultimately those are the depressive symptoms. So with this background, my research question was that what exactly the causes of the stress among the senior citizens during the period of this pandemic. So whether that your depression exists or there is no depression as such. So we classify the depression into 3 categories, like mild depression or no depression, then moderate depression, and finally that is severe depression. Another question that is coming to our mind is whether the comorbidity is the only predictive factor of depression or any other factor which is associated with creating a kind of depressive symptom among the older people. So that we also wanted to study in this project. Then what are the factors associated? If comorbidity is not the factor, then what are the other factors which are associated with the depressive symptom among the older people? So therefore, what we found is from the literature, that is previous literature, that sometimes there is a kind of social isolation factors that is creating some kind of depression. Then psychological factor, and here the psychological factor is the COVID fear factors. And sometimes that is financial efficacy, self-financing management kind of difficulties that older people they face. That these kind of your determinants or the factors which is driving the older generation towards depressive kind of conditions. So one very interesting literature that I found is during 2002, there was a cross-country study by WHO as well as that is the International Network for Prevention of Elder Abuse. What they found is that the older people, they generally face lots of challenges in terms of that is violence in the family, also in the society, emotional injury, humiliation, financial depression. Then this health issue that is also increasing because of comorbidity and your aging factor and other things. And all these factors, health issues particularly, that is creating a kind of a lifelong medication for the individuals, and which is also creating a kind of financial difficulty for the people. Also, another factor is that the changing family structure, that is from the joint family structure to the nuclear family kind of structure, or the death of your spouse, that is also creating some kind of issues with the older people. So that is a kind of your very important study that was conducted in 8 countries. So that I refer this paper or the study for my research. So what is the objective of my study? The objective, there are 3 objectives. Main objectives are like the level of depression among the older people. And this study is conducted in Orissa, that's a state in India, and where I live. So whether in Orissa this depressive symptom is there among the older people or not. Then what are the factors associated with the depressive symptom among the older people? And whether that is psychological factor because of your COVID fear, or social isolation factor, or financial efficacy dimensions, or that is comorbidity, which is which are the important factors which is creating a kind of your depressive symptom among the older people. So what is the methodology? What we exactly do? This study is based on the primary research. So once we are saying that is depressive symptom among the older people, how we are going to measure that depressive symptom? What we did is, there is 15 item that is geriatric depression scale. So that we use that one to identify whether the people they have some kind of depressive symptom or not. So that in our study, that 15 item geriatric depression scale is considered as the dependent variable. And this multidimensional model that we have used that includes social isolation, financial efficacy, psychological or that psychological factor is measured through COVID fear factor and the comorbidity. So these are 4 independent variables that we have taken, and the dependent variable is the depression scale, which is measured through this geriatric depression symptoms. So this psychological fear factor or the COVID factor, that is measured with the help of 20 questions, that is measured in 4-point Likert scale. All the questions are measured in 4-point Likert scale. So where we divide the responses into 2 categories: people those who are having some kind of a symptom of isolation, social isolation, and those who are not having some kind of social isolation symptom. Similarly, that is the social isolation is measured with that is De Jong loneliness scale, which is having 11 questions. So here also we categorize some people are having some social isolation kind of a symptom, or some are not having social isolation symptom. Then third part is that is financial efficacy. Here that is the scale is financial self-efficacy scale. So it is having 6 questions, and that is also measured in 4-point Likert scale. So where also we divide people those who are having some kind of a symptom of managing their difficulty, and those who are not having any difficulty in managing their financial efficacy during the COVID period. So therefore, we have one dependent variable, that is depression, and we have 4 independent variables. One is psychological fear, which is measured through 20 questions of COVID fear parameters. Then second is social isolation factor, and third one is financial efficacy factor, and fourth one is comorbidity. So as I've already mentioned, this is a primary study, and we have collected around 2,458 samples, particularly the people those who are having the age more than 60 years. That is considered in India, we consider that people who are having more than 60 years of age, they are considered as older people. So that consists of this number of samples. And for data analysis purpose, we use chi-square test and that is multinomial logistic regression to see that which are the factors which is driving the depressive symptom among the older people. And all responses are measured in 4-point Likert scale. And the initial analysis that says, and what we did initially is that all these independent variables are tested for collinearity, and we found that there is no existence of collinearity among all these independent variables that we consider for our study. And what we found initially from the demographic part of questionnaire, that around 58% of people, 58% of the people, depression among older people in the state of Odisha is estimated to be 58.36%. And the composition of the different levels of depression that includes, because what we did is we divide the total depression into 4 categories. One is no depression category, then mild depression, moderate depression, and severe depression category. So around 25.67% people are mild cases, followed by 21.92% are moderate, and 10.7% people are severe depression cases. And age-wise, if we divide the total depression symptom, so we found that you people those who are older, that is people above 71 years old, so their depressive symptom is much higher in compared to the other people those who are having age less than 71 years. So, and another thing is the data reveals that the female members are having more depressive symptoms than the compared to the male members. And what we did is initially that I told that for data analysis we use chi-square test, and the chi-square test result that indicates that out of these four independent variables, that is social isolation, financial efficacy, COVID factor, and comorbidity. And what we found is COVID factor, then COVID fear, then comorbidity, and social isolation. And these are significant variables. And financial efficacy is not significant. So the independent factors include, that is social isolation, financial efficacy, and COVID fear factors. So these are the three factors which are significantly influencing the dependent variable. And as I was saying, because another thing that I wanted to explain is why we use that your multinomial logistic regression. Because this dependent variable, as your depression, is having four categories: no depression, then mild depression, moderate depression, and severe depression. So since this is a categorical variable, so therefore we cannot use binary model. So we use multinomial logistic regression model. And in this model, we consider the severe depression as the reference group or the baseline category. And all other depressions like no depression, mild depression, and moderate depression is compared vis-a-vis that is severe depression. And the result of multinomial logistic regression is here. And I just make a summary of the findings that what we got. So far as no depression is concerned, that the social isolation and comorbidity are statistically significant. And other variables like financial efficacy and COVID fear is not statistically significant. If isolation symptom increase, then to be remain in the no depression category declines because of the negative slope, that is your coefficient value is negative. So what we can say is to remain in the no depression category will be declining, and more chance that more likelihood that people will be severely depressed. However, the comorbidity among older people, if that improves, then more likely that they will remain in no depression category. So this is the findings from the no depression and severe depression comparison. Then if you compare between the mild depression with the reference group, that is severe depression, what I found is that three predictors like isolation, COVID fear, and comorbidity are statistically significant, and financial efficacy is insignificant. What it indicates that if the isolation and COVID fear symptoms increase further among the older people, then more likelihood they will be severely depressed. And under the situation of improvement of comorbidity, they will remain under that mild depression category. So if isolation and COVID fear symptoms increase further, then those who are now in the mild depression category, they may be shifted towards the severe depression category. But if the comorbidity improves, then they will remain in mild depression category. Then third one is that is moderate depression, and in this moderate depression also we compare with the reference group, that is severe depression category. Then out of the four variables, only one predictor, that is isolation symptom, is statistically significant, and all other predictors are insignificant. What it indicates? This shows that if the isolation symptom increase further among the people who are in moderate category now, then they will be severely depressed from moderate to severe. So that means if isolation symptom again increase, so they will be severely depressed in future times to come. So all these levels of your depression, depressive symptoms like no depression, mild depression. So here that I have already mentioned, that is compared with the reference group or the baseline, that is severe depression. So what is my as I conclude? So my conclusion is that the social isolation, COVID fear factor, and the presence of comorbidity are found to be significant determinants of depressive symptoms among the older people during the period of COVID-19 pandemic. And financial efficacy factor, that is the difficulty in managing financial matters of the older people is not found to be a factor which is driving to people towards the depressive kind of condition. But this study is not free from limitations. So the limitation of the study is this study is concentrating on a particular state, that too in Odisha in India, right? So that is a kind of limitation. Another limitation is that we have taken only the 4 independent variables like isolation, financial efficacy, COVID fear, and comorbidity as the independent variables to determine the level of depression. So maybe if we'll take some other kind of predictors, so maybe the result will be different. So this is about my research, and I welcome questions.
Thanks very much for that paper, Dr. Ray. I think that it's a very interesting set of findings there, and I was just noting your finding about the different predictors being relevant in different levels of depression, which seems it might have some quite practical implications for how depression is managed in older populations. Certainly, it seems a neglected topic, so very interesting to hear about that. Thank you. Okay, we're going to move on now to our third and last paper, and this is from Dr. Ashok. Dr. Ashok is formerly professor in the Department of Psychology at Bangalore University and currently visiting faculty at the Centre for Education and Social Studies in Bangalore. He's a representative of the Indian Council of Social Science Research and has been involved in research projects in the area of management and entrepreneurship. And Dr. Ashok's paper is titled "The Role of Religious Institutions and Leaders During Pandemic, Implications on Technology, Process and People During the Fight Against COVID-19." Thanks very much, Dr. Ashok.
Thank you. Thank you. Thank you, Professor Elena and co-panelists. Greetings from India. I would be talking about the role of religious institutions and leaders during the pandemic implications. The reason for this would be India being a society. We have different perceptions with regard to any pandemic or any disease, and we talk in terms of health and well-being component is concerned, how exactly people tend to react to the health and well-being is an important component. So from that point of view, I would be discussing in terms of the role of religious institutions, how far the role religion itself has an impact on the well-being of the individuals are concerned. Okay, so I think I will skip this slide because already spoken about, and it's a well-known fact about the rates of COVID-19, say wave 1, wave 2, and the fear of wave 3, and across the globe and different nations, implications of COVID in terms of health and well-being affecting the entire life in there. I think that's where some statistics and other components are there. Now coming to religion, why religion is an important factor to deal with this sort of a pandemic situation is that when we look at religion, religion is a social institution. So whether an individual belongs to, again, when you talk in terms of institution, ascribed institutions and achieved institutions. So individual becomes automatically, whether one likes it or not, as soon as an individual is born in a culture, there is an influence of particular religion. So religion is a social institution, and it governs and regulates the behavior of the individuals through certain sanctions. So if you adhere to those, let us say, religious principles, etc., it approves your behavior. If you don't, there is a negative sanction with regard to that. And when we talk in terms of religion, associated with ethics, harmony, well-being, achieving harmony and achieving well through the principles and through the regulations, regulatory practices that are being given by the religion, prescribed by the religion, is an important factor. And then religion can have two different dimensions. That is where the micro dimension and the macro dimension. Okay, when you talk in micro dimensions, all those individuals who are into that particular religion, as in terms of a culture, in terms of a community, in terms of a religious group, it is applicable to up to all. And then you also have a micro perspective, that is where an individual belonging to a particular religion, how exactly the individual relates himself to that particular religion is an important factor. So this is where I may subscribe to a particular religion, I may not subscribe to a particular religion. As I said, so you don't have need to say, as soon as you are born, the religion is given to you, and later on, probably because of conversion and various other factors, you may change it. So that is where the micro and the macro dimension of religion has to be understood. And then when you talk in terms of religion, one of the important components that we need to look into is religiosity. Now, I was talking about, let us say, sanctions. The sanctions are normally in terms of the various rituals and practices that a religion prescribes, that this has to be followed or this has to be adhered. It can be in terms of festivals, it can be in terms of congregations, it can be in terms of, these practices become religiosity. The degree to which an individual adheres to these also tend to vary. That is where people tend to be more religious, or certain individuals may be less religious. So only on certain occasions they may adhere to this, or certain individuals may extremely adhere to these principles in everyday, etc. So that's where when you talk in terms of religiosity, differences can in terms of individual or the community level you can see. So at an individual level, at a community level, the religiosity, the types and dimensions of religiosity also may vary. Now, when you talk in terms of impact of religion or the influence of religion, the impact of religion can be seen in terms of two aspects. As I said, the degree to which you adhere to accept religious principles and etc. Based on that, people can be classified into believers and non-believers. So no matter what culture, no matter what religion are, so based on the degree to which individuals adhere to or subscribe to a particular, we can classify them in terms of believers and non-believers. And the impact also tend to vary depending upon whether they are believers or whether they are non-believers. So normally when we talk in terms of the impact, now when it comes to the pandemic situation is concerned, believers tend to say that it is a sort of punishment given by the God, given by the, let us say, the spirit and etc. So that is one particular aspect of it. And similarly, they may also say that it is a God's will, that one way to bring about harmony, bring about goodness in the society. So this effect, it's God's will. Or people also may, when it comes to the believers are concerned, people may turn towards the divine intervention. So a series of rituals and series of special, let us say, congregations or special pujas and other things may be performed in order to see divine intervention. If I can go back, when earlier pandemic like a plague and malaria were there, especially if you take in terms of an Indian culture, by the name of that particular god or that particular spirit itself, temples were built and particular. So that's where we had Plague temple. So the Plague temple was referred to the new god is created in the name of a plague, and then people started following or appeasing this particular let us say god in order to appease and then try to handle this sort of a situation is concerned. So that's how people tend to vary in terms of how seek divine intervention is concerned. Now, when it comes to explaining on this believers and non-believers, now this believers and non-believers, depending on whether they are believers or whether they are non-believers, you can look at the impact in terms of religion as a cure or religion as a curse. Okay, so those who are believers believe strongly that religion is a cure, so that it is a very effective means to deal with the pandemic situation is concerned. Whereas those people who are non-believers, they feel that religion is a curse. Now, first let me talk about the religion as a curse and then come to religion as a cure. Now, when it comes to religion as a curse, now you find that the pandemic is a punishment. So as I said earlier, so it is a punishment and everybody, there is no other way to escape from it, and we become succumb to that, or we become victims to that particular aspect is concerned. So since it is a punishment given by the god, or the god's will that so many people have to. Again, there are several let us say theories with regard to the evil and the good, the noble and the evil, and then ultimately, irrespective of the religion, the supreme power tend to bring about harmony or bring about the peace and well-being in the society by certain actions, punishing the people and etc. So that's where the God's will is a factor. And then religion as a curse because it's discrimination. It facilitates the discrimination. Now, probably when I talk in terms of, let us say, Indian multicultural, let us say, or multi-religious society like India, people start discriminating and people start distancing, or people start aspecting different, biases towards people belonging to different religions. One, when you say, for example, when I was talking in terms of adherence to religion, in terms of religiosity, and when you're talking in terms of religiosity, these religious practices that are performed by one religion is being criticized by other religions, saying that it is one of the source for spreading the disease, spreading the pandemic is concerned. So, for example, you talk about mass bathing or mass congregation and festivals. So, collective, performance of, festivals and etc. So, people come together, gather together, and when they gather together, then the spread of, the pandemic is more. So, it, different religion has a curse, because if people tend to adhere to that particular religion, and then it tend to discriminate the people belonging to one but same community, same nation in terms of the religion is concerned. And religion as a curse because, when you talk in terms of believers, hardcore believers, now they say that nothing is going to happen because it is a God's will and I have not done any sin. So no matter what, even if I don't take any injection, vaccination, etc., nothing is going to happen to me. So there is a resistance to change towards practicing safety procedures or hygienic procedures in terms of social distancing, in terms of social distancing, in terms of vaccination, all those. So people become resistant to change. And then, normalcy comes after a particular point of time. I need not have to do anything or, so that is where resistance to change tend to take place. So religion primarily as a curse can be seen in terms of as a punishment, as a God's will, as it encourages discrimination, and resistance to change is another factor. Now, coming back to religion as a cure. Now, religion as a cure, it can be seen in terms of four factors. One is a coping measure. So it acts as a coping mechanism when it comes to perception of pain, in the psychological concern. Okay, so it facilitates. If I belong to the religion, start practicing that particular. Again, there was an interesting information that during the pandemic COVID-19, more than 50% increase in people searching in the Google search engine for religion-related activities are concerned. So, what do you mean by that? In a normal situation, people may not be so concerned, so adhere to the religion, but during the pandemic, so adhering to the religion can can iron out the psychological impact of that. So that is where it acts as a coping measure is one. And religion as a cure, again, in terms of preventive measures. That means certain, let us say, religion itself, say, for example, some of the practices that are being prescribed by certain religions with regard to the health and hygiene in terms of food, in terms of diet, etc. So there are in the scriptures itself, they say during a particular period of time, during a particular, let us say, season, a type of food has to be consumed so that automatically your immune system can be, let us say, raised. And that is where, offering of, these things as a prasadam or as a to the god and then consuming it also act as a preventive measure. This is the second component is concerned. Religion as a cure, the third important component, again, I was talking in terms of micro and the macro aspect is concerned, it facilitates, it encourages altruistic behavior. Now, so that means the human nature, the goodness in the human nature comes out. In a normal situation, the individual may be egocentric, the individual may be self-centered, but during the pandemic component is concerned, reading the scripture or going through religious, let's say, scriptures will encourage, will enhance people to look beyond the self and then try coming to help the community at a larger level. Because when you talk about the pandemic, it is at a larger level, the impact is at a larger level, and then where it facilitates, encourages the altruistic behavior is concerned. And obviously, the next one, when religion as a cure and the perception of these health practices, hygienic practices, adhering to that definitely helps the individual towards the health and well-being component is concerned. Now, when you look at the way of life as prescribed by any religion, see, when it comes, I'm not talking about religiosity. Now, when it comes to the religious way of life, if one automatically follows that particular, let us say, way of life as prescribed by any religion for that matter, it automatically ensures a sense of well-being, a general sense of well-being is concerned. So that is where religion as a cure and religion as a curse is concerned. Okay. The next aspect would be now when it comes to the role of religious leaders. Okay. Now, when it comes to, let's say, how religion has an impact on the society, we can look at from, let us say, three aspects is concerned. One is the role of religious leaders. Another is increased use of technology. And then we talk in terms of, is it possible for us to replace religion by spirituality? Okay. And this is more important, not only during the pandemic, but also post-pandemic, returning to normality also. These three play an important role. How far the religious leaders can play a role in dealing with the pandemic situation is concerned. These religious leaders have a very high degree of persuasiveness. Okay, so the degree to which people, again, when you're talking about persuasiveness, whatever the leader says, there is a greater degree of acceptance of this. So there are several mutts and there are several religious institutions, especially if I talk in terms of let us say, Indian situation is concerned, irrespective of the religious institutions that are found in India, whether it is temples or mutts or mosques or churches, etc. These religious leaders, came forward to deal with the pandemic in a very effective manner. Wide range of, let us say, activities were, let us say, performed or were actually enforced by these religious leaders. One is through the continuous, let us say, advocating them or educating them about the importance of health and hygiene or adhering to the social distancing component is concerned. These temples, churches, mosques itself maintain social distance. So they closed their temples or they reduced the hours of prayer, and they also maintained in their own sanctum sanctorium itself maintain the social distance. Or some of the components. So the type of activities open to religious institutions itself was regulated. One, educating the people towards importance of vaccination, importance of hygienic practices, the second component is concerned. And some of these institutions had the centers, they not only had only religious place or a sanctum sanctorium, but it also had certain housing facilities also in terms of rooms, in terms of other factors. So they converted these centers into quarantine centers. Okay, so this is where the more religious leaders with an open mind started converting these religious centers into quarantine homes. So people who are affected, people wanted some sort of a distancing have to be kept separately. So this was the second component that was used. So role of religious leaders is the second component or the primary way in which the religious leaders played an important role can be seen there. And thanks to development in the technology. Okay, so technology has come in a big way in religious leaders or the religion accepted the technology with a wholehearted or with an open hands. So there are novel ways of reaching people, religious needs using technology. Okay, web series have come in, or you talk in terms of religious discourses were let us say presented through YouTube channels or their own websites they created, and these temples or religious institutions started giving open those let us say religious centers which can be seen sitting at their home, irrespective of whether they are normal, affected, or positive, or suspected. Irrespective of these different sections of people, now people could have access to their religious needs, whether it is in terms of darshans or seeing or visualization of the various rites that is being performed, rituals performed at the temples and religious centers. They could look at it, view it from their home, or say, for example, some of these things, offerings that were made was directly sent through mail or sent through various agencies at their doorstep is the second component. And we had an interesting practice that was there. I think one of the ISKCON centers took the entire god in a chariot, and that particular chariot was pulled inside the hospital wards, so that sitting at their wards, recuperating or getting healed, process of healing itself, they could see the have the darshan of the idol and etc. So this is another use of technology for this particular aspect. So increased use of technology. So technology has become played a very significant role, and religion has with open mind, open hand, accepted the technology and is making use of it. So this is the second component that can be seen. Now,
about 3 minutes left, Dr. Ashok.
Okay, thank you. So what I'm trying to say here is that especially in a multicultural society, it is necessary to, in terms of replacing the religion with the spirituality. So that is where an important component is concerned. So I think I will go to say, when it comes to the spirituality, okay, why spirituality is promoted is because spirituality helps an individual to move from I, that is the self, to the family, to the community, and to the world. So this is where, when you talk in terms of a pandemic, it is looking beyond from the self to the family, to the community, to the world itself. And that particular perspective is facilitated by the spiritual component is concerned. So spirituality is an important factor because this spirituality has three perspectives: human resource perspective, that is where enhances individual well-being and quality of life; philosophical perspective, provides a sense of purpose and meaning at life. So probably earlier speaker was talking about depression, suicidal tendency. Probably this spirituality will encourage the sense of purpose and the meaning at work, and that's where pandemic can be handled. Interpersonal perspective, spirituality provides a sense of interconnected and community component. That's where I was talking about altruistic behavior can be encouraged, can be enhanced by spirituality. And lastly, what I would like to say is that with regard to the policy perspective, how religion can effectively be used in order to deal with the post-pandemic situation is concerned, recognition of interdependence among religious institutions to promote healthy practices, while effective use of technology is an alternative, check and balances towards abating threats of data privacy, security, and management from cyber attacks is an important component, and promoting spirituality as an effective coping is more beneficial for both believers as well as the non-believers, and promoting and acknowledging the indigenous pandemic by involving religious institutions play an important role. Thank you very much.
Thanks very much, Dr. Ashok. They're very big picture reflections you've got there on, the impact of the pandemic, and perhaps in terms of religion and spirituality, creating a new normal out of the circumstances that have prevailed over the last couple of years. So, yeah, I'm interested if we can have more discussion on that.
Yeah.
So I'm just going to put myself back on the screen. Okay, so we've now got a bit of time left to have some questions and discussion. I just want to remind you that you can put your questions in the Q&A button, just press that, and also ask questions to the speakers. Any comments you have, anything you'd like to say, please start. We'll just await some questions. There's some very interesting material here for us to think about from 3 quite different perspectives. So let's see. Perhaps while people are thinking of their questions, I might just come back to Dr. Pernia. One of the things that interested me about your study was when you showed those word maps for anger and boredom, anxiety, etc. There, particularly for anger and boredom, there were quite a lot of non-English, I assume Tagalog words. There weren't so many for optimism, hope. They seem to be more expressed in English. And English certainly did seem to be the dominant language, but a couple of those emotions did seem to elicit more of the, the local languages. And then when you, I guess that's one question, that I just wonder if you have any comments on that. And then the other question I had was about the fact that when you created the videos, at least the couple that we saw, they were in Tagalog. They weren't in English, or they were presented, it seemed to be, to a Tagalog speaking audience. So there just seemed, I was interested in that difference between the social media presentation and the videos. I wonder if you could say a bit more about that.
Okay, first about the comments being in Tagalog when it comes to anxiety and anger. Well, I think it's maybe it's a phenomenon that is common to many cultures, but when you curse, it is easier to curse in your own language. So maybe that's why, okay. Some words of profanities are, it's also one way of getting around the social media rules, a lot of our, several social media would automatically edit out. There are some words that, will not be accepted. So some are creative, they use the F word, but they put slashes in between. But then again, if you use your local language, and in the Philippines, we have so many languages, and that's more expressive of your feelings of disgust, anxiety, some of these words, some of these emotions are really more, more describable, more, how do you say it, more attuned to your culture. So maybe that's why. Hope, as you said, the more positive ones. I would think it has to do with empathy more than hope, because the empathy, the calls for donations, this the altruism, for example, that Dr. Ashok uses. That was coming out. It was a maybe that was something of our religiosity as well, maybe that's why. And then the question about language, why did we choose to do it in Filipino? Well, you'll notice that there are a lot of English words woven into the dialogue, because that is our lingua franca, especially in the metropolitan area. A lot of our English has integrated Filipino terms, and a lot of our Filipino integrates a lot of English words. So, there's something here that one can understand, even though you do not speak the whole language. The other thing, primarily, is that our targets here are the seniors who belong to the lower middle and the D classes. For them, television is still a main medium, and these days, the internet has become some kind of a media, some kind of television for them as well. And there are so many channels on the internet, and the ones that are, I guess, popular are the ones that still use our local languages. And besides, those when adopted and used in other areas of the country, those are still understandable. You know, that type of Filipino, that type of Tagalog will still be understood whether it is in the Ilocano regions in the north or the Visayan regions in central Philippines or in Mindanao. You know, so so that's why we chose to do it that way.
Thanks very much. That's a really interesting response. I don't know if we don't seem to have any questions yet. Don't be shy, members of the audience. Please put your questions into the Q&A. Meanwhile, I'll press on because I've got plenty of questions. I just wondered, Dr. Ray, just thinking about your very interesting data there, I just had a couple of questions. I mean, the first one was, I just wondered who administered all the scales. That was a really impressive number of participants in your study. So I was rather interested in, you know, how that data were obtained. And I suppose one of the things that interested me thinking about the, you know, practical or policy implications of your findings was just that the one predictor that seemed very intransigent was the social isolation, in that, you know, particularly in the very serious cases of depression. And so it's interesting, isn't it? Because social isolation is seen as an advantage in the situation of COVID. But I just wondered if you could perhaps say a bit more about that as well, and whether you see that as something that can be redressed, you know, as an outcome of your study, or be approached through different policy initiatives.
So, no, our objective was to see that how the older people, they are feeling isolated. Because you see, during this COVID-19 kind of pandemic, that your isolation, social distancing, that is the norm, that everybody need to adapt that one. But our objective was to see that how people, they feel like, right? So feeling in the sense like whether always I'm thinking like nobody is there to care for me, nobody is there to help me. If some kind of your COVID-19, I'll be turned positive, then nobody is there to carry me to the hospital. Those kind of your questions that we ask actually, right? So, so to see that how often that people, older people generally, they feel like isolated, right? So that's the objective. And you are right, because of your government policies and other things during this time, that your social distancing, social isolation, that will be there. That is to prevent the spread of the virus. But if somebody is feeling that way always, that means, so that may cause a kind of your depression. That was our objective study, along with the other kind of your feelings, like your, suppose always there is a kind of your tendency of the people that we need to wash our hand always, right? So during this time, so that may be a kind of your fear always, even if you are there inside your house, but always you are just cleaning your hand. So that means there is a COVID fear. So those kind of your feelings actually, all these are nothing but your feelings. So that we wanted to study through this questionnaire.
Yeah, okay. Thanks very much. Look, I have got one question for you from Dr. Pernia, but I just wanted to first ask Dr. Ashok if he could, again, it's just another, observational question of mine, just about when you arrived at this idea of, clearly feeling that maybe there's a potential for a new normal here. And I just wondered if you could say a little bit more about how you see this more spirituality framed mode of, religious interaction or thinking, how you see it developing, perhaps just in a couple of minutes, because I just then want to make room for the other question.
Okay. It's an interesting component now, because especially when it comes to the younger generation is concerned, religion is becoming weak, and because of the religiosity perspective is concerned. So people are looking for an alternative to the religion is concerned. So, because when you talk in terms of, let us say, the purpose in life, okay, so if, especially from a psychological perspective is concerned, suicidal ideation is predominantly can be related to the lack of purpose in life. So thanks to technology, thanks to various changes, rapid changes that is taking place in the society. So as a result of it, what is happening is the materialistic orientation and running towards the success is becoming an important component, especially when you talk in terms of a younger generation is concerned. And the ego is bloated to such an extent that a small pinprick to the balloon will burst. And that's where people do not believe in the religion, or the acceptance of religion is becoming low and low. And when that happens, people are looking for an alternative to religion. That's where most of these centers are coming up. They may not call it themselves as a religious leaders as in terms of sects or sections are concerned, but they are promoting these, let us say, the spirituality at a larger level. That's where I was talking about the practices and the principles are more from moving away from individual, family, community to the universe component is concerned. And if these practices are being, let us say, practiced now, probably youngsters are being attracted towards that. And that would be a primary means. And I think I am optimistic and feel that this is becoming the normalcy now. Probably after a few decades, there may be a need for another alternative for this also.
Thank you. It sounds like you've got another whole research project there, analysing how this spirituality phenomenon unfolds in the society. Just to go back to another question for you, Dr. Ray, it's a very practical question from Dr. Pernia. Are there interventions that use technology to help isolated seniors from depression?
Yeah. So you see, because technology part that we have included that one in the COVID fear, because you might have seen during this, because everywhere the first wave and your second wave that was there, including India and elsewhere as well. So many times what people generally do, including me initially, that always every moment you switch on your television and see that what is the kind of your positive initially actually during March, April 2020. So that means we generally refer the media reports for your trend that is happening, right? So that is also creating a kind of your COVID fear among the people. If frequently somebody is getting the news from the media about the COVID trend and other things, so that is creating a kind of difficulty. But your question is something different. Your question is how your technology is going to help the senior citizens to avoid the kind of depression. I think this is your question, right, Dr. Pernia? Yeah.
That's right. That's correct.
Yeah. So that means again the question is, because our type of the questions that we have included is how frequently, because you see in back of your mind somewhere that's there. You are feeling isolated, because of that you are taking the help of your technology, iPad or something else, okay, to listen music or something else. That means to avoid that one. That means our objective is to see here, how often that your isolation kind of your feeling that is coming. Okay, so that we wanted to study. Okay, maybe or some people they are using that your technology to avoid some kind of your isolation at home, because people are completely locked up inside their house. So that means the technology is there, but completely you are depending on technology to avoid isolation. So that feeling, how often that is coming, that is our objective to study. I hope that I address your question.
Yeah. Yes, you
to add on to that, the National Institute of Mental Health and Neurosciences in Bangalore, one of the leading institutions, have started telecounseling and those aspects. And even many private practitioners have started telecounseling. So use of technology has been facilitating the people.
Yeah. The reason that I asked that question was more particular to COVID patients who are senior. We know that if you, the worst type of COVID is such a, is a disease that isolates you, especially when you are hospitalized and when you are a serious case. You can't be visited. There's no hand holding. There's nothing of those. So that's why when you were making your presentation, Dr. Ray, I could imagine, the isolation that these patients themselves feel. So that was why I asked.
That's true. Okay, thank you.
Okay, look, thank you to our three speakers and to the audience. I hope you enjoyed this session. There's clearly plenty to talk about, and actually, as we speak, there's some interesting connections and crossovers between these papers, which obviously are worthy of more consideration. So we'll have to take that up at another time. I think I'd just like now, it's my job to announce we're having a short break for this conference, a 30-minute break, and we will be finishing up, but the next session, session 4, is called Lockdown, How COVID Has Changed How We Live, Learn and Work. Obviously, a great follow-on from this session. It will begin at 5:30. And you can join that webinar by using the specific session 4 link mailed to you. So hope to see some of you at the next session. Thanks, everybody. And thanks again to our speakers. Marvelous.
Thank you, Dr. Linda. Thank you, Dr. Linda, for